Okay, so let's talk about the gross anatomy of the humerus. That's the bone of the arm. Okay, it's a long bone that is has an upper end. Okay, at the upper end there is the head, which is of course hemispherical, and the head faces medially, superiorly, and posteriorly, and of course articulates with the glenoid cavity. Then we have the second part called the anatomical neck. The anatomical neck is the slight constriction at the neck, and then we have the greater tubercle. The greater tubercle is more lateral. The supraspinatus, infraspinatus, and teres minor muscle attaches to this greater tubercle. Then we have the lesser tubercle, which is more anterior compared to the greater tubercle or greater tuberosity. Okay, so here we have that's the lesser tuberosity. We have muscular attachment like the subscapularis muscle, and then we have the intertubercular groove, also known as the intertubercular sulcus. Okay, the long head of the bicep tendon passes through it. Then we have the pectoralis major muscle, attaches to the lateral lip of the intertubercular sulcus, and then we have the latissimus dorsi, okay, that attaches to the floor of the intertubercular sulcus. Then, of course, the deltoid tuberosity in the shaft. Now we are talking about the shaft. In the shaft, we have the deltoid. Okay, so on the shaft, okay, we just finished talking about the upper end of the humerus. Now on the shaft, we have prominent deltoid tuberosity, which is located laterally. Then we have the radial groove, which is located posteriorly, and then related to this part is also the radial nerve, which passes through the radial groove. And then we also have related to the shaft is the profunda brachial artery. Now talking about the lower end, in the lower end we have the capitulum that articulates with the head of the radius, and then we have the trochlea. The trochlea is more medial and articulates with the ulna. Then we have the fossas. We have radial fossa, which is anterior. We have the coronoid fossa, which is posterior. And then we have the epicondyles. We have the two epicondyles. We have the medial and the lateral epicondyle. For the medial epicondyle, behind the medial epicondyle, we have the ulnar nerve, which is behind it. And then, of course, the lateral epicondyle too. Now, what are the clinical notes of this? The clinical notes of, okay, talking about the clinical notes, the surgical neck, if the surgical neck fractures, then the axillary nerve will be affected. For the mid-shaft fracture, remember I said that the radial nerve passes through the radial groove at the posterior shaft. So if the mid-shaft fractures, we have the radial nerve will be affected. Then the supracondylar fracture, once there's a supracondylar fracture, it means the brachial artery will be affected. Now for the functional summary, the clavicle, remember in my last video I said the clavicle, what this one does is that strut and shock absorber. The scapula is for mobile platform, then the humerus now is a lever for upper limb movement. So together these three bones, a maximum range of motion at the shoulder, the cost of stability. So which means that the shoulder joint, has a lot of motion to it, but at the cost of stability. So maybe in the next video I'm going to be talking about the shoulder joint. Okay, so that's what we're going to be talking about. Okay, so maybe we should talk about the shoulder joint now. Since we are saying that together this bone, they help the movement of the upper limb, a lot of mobility at the expense of stability. So let's talk about the shoulder joint, also known as the glenohumeral joint.